Welcome to another deep dive, everyone. Today, we're going to tackle, the pretty big topic, actually.
That's right.
We're going to be talking about the neurological system.
It's a big one.
Yeah, and we're going to try to help you understand it, right?
Yes,
This is for all of you who are prepping for that big nursing school exam.
exactly.
And this is a topic, obviously, you're going to need to know frontwards and backwards.
Mm-hmm.
Seizures, multiple sclerosis, Parkinson's, Guillain-Barré syndrome,
We're going to hit them all.
big hitters.
Yeah.
We're going to try to help you make sense of these things so you can be the best nurses you can be.
That's the goal. Not just to pass the exam, but to really understand these conditions.
Right, because you're going to have to care for patients who have them.
Exactly.
So let's jump right in, shall we?
Let's do it.
Let's talk about seizures first. I think when most people think of seizures, they picture like dramatic convulsions.
Yeah,
right?
the classic Hollywood seizure.
Yeah, but that's not always the case, is it?
Oh, definitely not. Seizures can present in all sorts of ways, and they can be caused by a bunch of different things, too. Infections, brain tumors, you name it.
I've even heard that something as common as alcohol withdrawal can cause seizures.
Oh, absolutely. It's actually a pretty common cause of seizures in people who suddenly stop drinking heavily. The brain's just not used to functioning without that constant alcohol input.
Wow, so there's a lot more to seizures than meets the eye. And you were saying that the causes can actually change as people get older.
That's right. After age 50, the most common culprits behind new onset seizures are actually strokes and tumors.
Really? So taking a thorough patient history is absolutely critical, especially with older patients.
It can be life-saving, really. Knowing those key details about a patient's history can help us pinpoint the cause of their seizures and get them the right treatment faster.
So let's break down what happens during a seizure. I was thinking about it earlier. It's almost like a play with different acts, right?
I like that analogy.
Yeah, so there's like the before, the during, and the after. Each stage has its own set of signs and symptoms.
Exactly. So think of the prodromal phase as the first act. It's the time leading up to the seizure.
The foreshadowing.
Exactly. And it can be kind of subtle. The patient might seem a bit off, maybe irritable, confused, complaining of a headache. Sometimes they even have an aura.
Aura. Like a mystical glow.
Not quite. A seizure aura is a sensory warning sign. It could be anything from dizziness and tingling sensations to visual hallucinations or strange smells.
Wow, so the brain's sending out an SOS signal before the main event.
Exactly. And then, bam, the ictal phase hits. This is the seizure itself.
The climax of our play.
Exactly. Now, this is where we might see those classic convulsions, the stiffening and jerking movements. But it can also involve more subtle changes, like a loss of consciousness, staring spells, or even just twitching in one part of the body.
So there's a whole spectrum of seizure activity.
There really is. And then after the storm comes the postictal phase, the resolution of our play. This is the recovery period after the seizure.
The curtain closes.
Right. The patient might be exhausted, confused, have a headache, or even experience temporary paralysis. It can take minutes or even hours for them to fully recover.
Wow, that's quite a journey the body goes through.
Yeah.
And you were saying that some seizures are so subtle that they can easily be missed.
Oh, absolutely. Take absence seizures, for example. They're often called daydreaming seizures because the person just sort of zones out for a few seconds, staring blankly. You might not even realize they're having a seizure unless you know what to look for.
So someone could be having multiple seizures a day and no one would even know.
It's possible. And that's why it's so important for us as nurses to be super observant and ask the right questions.
That's a good point. Observation is key. Now, when we talk about those more noticeable seizures, those are usually what we call tonic-clonic seizures, right?
Right. Those are the ones most people think of, the full body convulsions, stiffening, jerking. They can be pretty scary to witness.
And dangerous too, right? I remember learning about potential complications like cyanosis from holding your breath, biting your tongue, even incontinence.
Yeah, all of those can happen. That's why it's so important to protect the patient during a tonic-clonic seizure, making sure they're in a safe position, protecting their head, and loosening any tight clothing.
Makes sense. And speaking of seizures that pose safety risks, what about those atonic seizures? The ones where the person just suddenly collapses.
Oh yeah, those are scary. They're also called drop attacks because it's like the person's muscles just suddenly give out.
And that obviously puts them at a huge risk for injury.
Huge. So for patients who have atonic seizures, fall precautions are essential. Think bed alarms, close observation, maybe even a helmet if they're prone to head injuries.
A helmet, wow. So we've got tonic-clonic seizures and atonic seizures. But there are a few other types of generalized seizures, right? What about tonic seizures?
With tonic seizures, you mainly see that sudden stiffening of the muscles. Again, a big falling risk.
Okay, so similar to atonic seizures in terms of safety concerns.
Exactly. Then there are clonic seizures, a bit rarer, and they involve those rhythmic jerking movements. But unlike tonic-clonic seizures, the jerking might not be symmetrical on both sides of the body.
Interesting. So you might see one arm jerking, but not the other.
That's right. And last but not least, we've got myoclonic seizures.
Myoclonic, that one always sounds a bit intimidating.
It's actually just a sudden, brief muscle jerk. It can affect different parts of the body, arms, legs, face, kind of like a really strong twitch.
Okay, so those are all the generalized seizures, the ones that involve the whole brain. But what about focal seizures? Those are a bit different, right?
They are. Focal seizures start in a specific area of the brain, kind of like a spotlight shining on one spot.
So the symptoms depend on where that spotlight is focused.
Exactly. If the focus is in the motor cortex, which controls movement, you might see involuntary twitches or spasms. But if it's in the sensory cortex, which processes senses, you might get weird sensations, hallucinations, even déjà vu.
Déjà vu during a seizure. That's wild.
It can happen. And we can break down focal seizures into two main types, aware and impaired awareness.
Okay, so tell me about aware seizures.
With aware seizures, the person is fully conscious, but they're experiencing these unusual sensations or movements. Imagine your hand suddenly moving on its own, but you know it's happening. Can be pretty freaky.
It sounds a bit like those moments where your leg falls asleep and starts tingling uncontrollably, but multiplied by 100.
Yeah, kind of. Now, with impaired awareness seizures, the person's consciousness is actually affected.
So they're not fully present during the seizure.
Exactly. They might seem confused, dazed, or out of it for a few minutes. Imagine someone staring blankly while repeatedly buttoning and unbuttoning their shirt, oblivious to what they're doing.
It's amazing how varied these seizure presentations can be.
It is, and it just goes to show how crucial it is for nurses to have sharp observation skills. You really need to pay attention to the subtle details to differentiate between the different types of seizures.
Absolutely. It's not just about recognizing that a seizure is happening. It's about understanding what kind of seizure it is so you can provide the appropriate care.
I couldn't have said it better myself. Now, there's one more type of seizure-like event we need to touch on. Psychogenic non-epileptic seizures, or PNES for short.
Oh, PNES. Okay, what are those all about?
Well, they look like seizures. They really do. But they're not actually caused by abnormal electrical activity in the brain. They're often rooted in psychological distress.
So like a physical manifestation of emotional trauma or stress.
Exactly. And it's important to remember that while they're not epileptic seizures in the traditional sense, they're still very real and distressing for the patient.
That's a good point. It's not about minimizing their experience just because the underlying cause is different.
Absolutely. And treating PNES effectively requires a more holistic approach, addressing those underlying psychological factors.
Right. It's a reminder that we need to treat the whole person, not just the symptoms we see.
Couldn't agree more. Now, while most seizures are relatively brief and self-limiting, there are some serious complications we need to be aware of. One of the scariest is status epilepticus.
Status epilepticus. That sounds pretty intense.
It is. It's a life-threatening condition where seizures either don't stop at all or they happen one after another without the person regaining consciousness in between.
So basically the brain is stuck in seizure mode.
Exactly. It's like a runaway train of electrical activity, and it can cause serious damage. We're talking brain damage, breathing problems, heart rhythm disturbances, even death if it's not treated quickly.
Wow, that's really sobering. So time is of the essence in recognizing and treating status epilepticus.
Absolutely. Every minute counts. It's a true medical emergency.
Okay, and you also mentioned something called SUD. What does that stand for again?
SUDP stands for sudden unexplained death in epilepsy.
Sudden unexplained death in epilepsy. That's a bit of a mouthful.
I know, right? It's a scary thought, but thankfully it's rare. It basically refers to sudden death in someone with epilepsy that's not directly caused by a seizure or any other known medical condition. We still don't fully understand why it happens, but it's a reminder that even seemingly well-controlled seizures can have serious consequences.
It's a good reminder that we need to be vigilant about managing seizures and supporting our patients in every way we can. And speaking of support, we have to talk about the cognitive impairments that can be associated with seizures.
Right. It's not just about the physical effects of the seizures themselves. It's also about the impact they can have on a person's thinking, memory, and overall brain function.
So someone might experience problems with concentration, memory lapses, slowed thinking. it can really affect their daily life.
Absolutely. And it can be really frustrating for patients because these cognitive changes can be subtle and hard to explain to others. As nurses, we need to be sensitive to these challenges and offer support in any way we can.
So it's about more than just managing the seizures themselves. It's about helping our patients manage the impact those seizures have on their lives.
Exactly. And that includes addressing those cognitive changes and connecting patients with resources that can help them cope.
Speaking of impact, what about seizures that happen during pregnancy? Those must be particularly scary.
They can be. We call those perinatal seizures. They can happen any time during pregnancy or right after birth, and they can pose risks to both the mother and the baby.
What kind of risks?
Well, for the mother, there's the risk of injury from the seizure itself, of course, but seizures can also disrupt blood flow to the placenta, which can lead to fetal distress or even premature birth.
And for the baby?
Seizures during pregnancy can increase the risk of developmental delays, learning disabilities, and other neurological problems in the child later on. It's definitely a situation that requires careful monitoring and management.
So it's a lot for both the mother and the baby to deal with. Okay, so we've talked about what seizures look like, some of the potential complications, and the impact they can have on a person's life. But how do we actually go about diagnosing them?
Well, like with most medical mysteries, it all starts with a good history.
Back to detective work.
Exactly. We need to gather as much information as possible. When did the seizure start? What happens during the seizure? Are there any triggers? How long do they last? How does the person feel afterward?
And then, of course, we have the physical exam.
Right. We're looking for any signs of neurological problems, weakness, numbness, changes in reflexes, coordination issues.
So we can pinpoint where in the brain the problem might be originating.
Exactly. But the gold standard for diagnosing seizures is an EG.
EG, electroencephalogram. That's the one with all the wires and the wavy lines, right?
That's the one. It measures the electrical activity in the brain, and it can help us identify the specific type of seizure activity that's happening.
So it's like a window into the brain's electrical storm.
Exactly. And depending on the situation, we might also order imaging studies like an MRI to look for any structural problems in the brain that could be causing the seizures, like tumors or lesions. And don't forget about blood work. Metabolic disorders can also trigger seizures, so we'll want to check things like blood sugar levels, electrolytes, and liver function.
So it's a multi-pronged approach using different tools to gather information and arrive at an accurate diagnosis.
Exactly. It's like piecing together a puzzle. And once we have all the pieces, we can start talking about treatment options.
All right, so let's shift gears and talk about how we manage seizures. Medications are usually the first line of defense, right?
They are. And thankfully, we have a lot of effective medications to choose from.
And how do these medications work? What are they actually doing in the brain?
Well, most of them work by stabilizing nerve cell membranes. They basically make it harder for those sudden bursts of electrical activity to happen.
So they're like calming the electrical storm.
Exactly. And that can significantly reduce the frequency and severity of seizures.
That's great. I know there are a lot of different seizure medications out there. Are there any specific ones that nurses should be familiar with?
Well, some of the most common ones are phenytoin, carbamazepine, valproic acid. And it's really important for nurses to understand how these medications work, their potential side effects, and how to monitor patients who are taking them.
What are some common side effects to watch out for?
Drowsiness, dizziness, problems with coordination are pretty common, especially when starting a new medication or adjusting the dosage. And it's crucial to emphasize to patients that they should never stop taking their medication abruptly.
Why is that so important?
Abruptly stopping these medications can trigger a seizure, sometimes a more severe one. It's like suddenly cutting power to a computer. Things can go haywire.
Yeah, that's a good analogy. It really highlights the importance of patient education.
Absolutely. Patients need to understand their medications and be active participants in their own care.
And it's not just about those common side effects, right? Some of these medications have more serious potential risks.
That's right. Some can affect liver function, so we need to monitor liver enzymes regularly. Others can cause blood disorders, so we need to keep an eye on blood counts.
And some can even interact with other medications the patient might be taking, right?
Exactly. It's a lot to keep track of, but it's all part of being a good nurse.
So it's a balancing act, trying to control the seizures while minimizing the side effects. And what about those generalized and non-motor seizures we talked about earlier? Are there specific medications for those?
There are. Ethosuximide and divalproex are often used for generalized seizures, and clonazepam can be effective for non-motor seizures. But again, it's all about finding the right medication and the right dosage for each individual patient.
It's like personalized medicine for seizures.
You could say that.
Okay, so medications are the mainstay of treatment, but what happens when they just don't work? Is surgery ever an option for seizure control?
It can be, but it's not for everyone. Surgery is usually only considered if the seizures are very severe, they don't respond to medication, and they originate from a specific area of the brain that can be safely removed.
So it's a pretty big decision.
It is, but for some patients, it can be life-changing.
You know, I keep hearing about the ketogenic diet for seizure control. Is there any truth to that?
The ketogenic diet is a very high-fat, very low-carb diet that forces the body to burn fat for energy instead of glucose.
So it's like putting the brain on a fat-fueled engine.
Something like that. And for some people, especially children, it can help reduce the frequency and severity of seizures. But it's not a magic bullet.
And it's not exactly the easiest diet to follow.
Definitely not. It's pretty restrictive, and it can be tough to stick to long term. And it does come with some potential side effects like kidney stones and high cholesterol, so it needs to be carefully monitored by a healthcare professional.
So it's not for everyone, but it's good to know that there are alternative options out there.
Exactly. And then there's vagal nerve stimulation.
VNS, that's the one where they implant a device, right?
That's right. It's a small device, similar to a pacemaker, that's implanted under the skin in the chest. It sends regular electrical pulses to the vagus nerve, which runs from the brain down to the abdomen.
And that somehow helps control seizures.
It does. We don't fully understand how it works, but it seems to help regulate brain activity and reduce the frequency of seizures.
So it's another tool in our arsenal.
Exactly. And for some patients, it can be a really effective option, especially when medications alone aren't enough.
Wow, so many different treatment options. But let's not forget about the vital role nurses play in seizure management.
Oh, absolutely. Nurses are on the front lines, and they can make a huge difference in the lives of patients with seizures.
Okay, so let's talk practical nursing care. What are some of the key things nurses need to keep in mind when caring for a patient with seizures? I imagine safety is a top priority.
Safety is always number one. We need to make sure the environment is safe for the patient. That means padded bed rails, clear walkways, having suction equipment readily available, all those basic but essential things.
And what about during a seizure? What should a nurse do?
Well, the first thing is to stay calm and call for help.
That's easier said than done, I imagine.
It can be, especially if it's your first time witnessing a seizure, but the key is to remember your training and focus on protecting the patient.
Okay, so call for help, then what?
Help the patient to the floor if they're standing, protect their head, loosen any tight clothing, time the seizure, and most importantly, never put anything in their mouth.
Why not? I thought that was the thing to do.
That's an old myth. It's actually really dangerous to put anything in someone's mouth during a seizure. They could choke on it or damage their teeth.
So it's all about observation and protection.
Exactly. And if the seizure lasts longer than 5 minutes, or if the person isn't breathing properly afterward, call 911 immediately.
Okay, good to know. Sounds like documentation is really important too, making sure we record all the details of the seizure and how the patient responded.
Absolutely. Detailed documentation is crucial for the rest of the healthcare team. It helps us track the patient's progress, identify any patterns or triggers, and adjust the treatment plan as needed.
So we've covered the acute management of seizures, but what about the long term? What are some things nurses can do to help patients manage their condition and live fulfilling lives?
Education is huge. We need to empower our patients to understand their condition, manage their medications, and recognize their triggers.
Triggers being things that might make them more susceptible to seizures, like stress, lack of sleep, certain medications.
Exactly. And we also need to help them make lifestyle changes that can reduce their risk of seizures, like getting enough sleep, avoiding alcohol and drugs, managing stress.
So it's about more than just treating the seizures themselves. It's about helping them live a full life, despite their condition.
Exactly. And that might also involve connecting them with support groups or other resources. Living with the seizure disorder can be isolating and scary, so it's important for patients to know they're not alone.
It's a team effort.
It really is. And nurses are an integral part of that team.
Okay, before we move on to multiple sclerosis, I want to make sure our listeners know when to seek emergency care for seizures. What are those red flags that should send someone rushing to the hospital?
Well, a first-time seizure is always a reason to seek immediate medical attention. And if a seizure lasts longer than 5 minutes, if the person doesn't wake up afterwards, if they're injured during the seizure, those are all signs that something serious could be going on.
So it's better to err on the side of caution.
Absolutely. When it comes to seizures, it's always best to play it safe.
Okay, good to know. Now let's switch gears and talk about multiple sclerosis. This is a condition where, well, the body's immune system basically goes rogue, right? It starts attacking its own nervous system.
That's a pretty good way to put it. It's like the immune system gets confused and starts mistaking the myelin sheath, the protective covering around nerve fibers, as a foreign invader.
So the body is essentially waging war against itself.
Exactly. And that can have some pretty devastating consequences.
And this is a relatively common condition, right?
It is, unfortunately. Millions of people around the world are living with MS.
So the odds of encountering a patient with MS during your nursing career are pretty high.
Very high. So it's definitely a condition you'll need to know inside and out.
Okay, so let's break it down. What exactly is happening when the immune system attacks those nerve fibers?
Well, think of the myelin sheath as the insulation around electrical wires. It helps those nerve signals travel quickly and efficiently.
So in MS, that insulation is being stripped away.
Exactly. And as that insulation breaks down, those nerve signals start to get disrupted. It's like static on a phone line.
So the messages from the brain aren't getting through properly.
Right. And that can lead to a whole range of symptoms depending on which nerves are affected. Muscle weakness, fatigue, vision problems, numbness, tingling, problems with balance and coordination. It can really affect every aspect of a person's life.
Wow, so it's not just one specific symptom. It can manifest in so many different ways.
Exactly. And that's one of the things that makes MS so challenging to diagnose and treat. There's no one-size-fits-all approach.
It sounds like we need a quick refresher on the anatomy of a neuron, just to remind ourselves how these nerve signals work.
Sure. So a neuron is like a tiny messenger. It carries information throughout the nervous system.
And it has different parts, right?
Right. Imagine a tree. The cell body is like the trunk of the tree, the control center of the neuron. The dendrites are like the branches receiving signals from other neurons. And the axon is like the root system, a long fiber that transmits signals away from the cell body to other neurons or to muscles.
And that's where the myelin sheath comes in, right? It's that protective covering around the axon that helps those signals travel efficiently.
Exactly. It's like the insulation that keeps those electrical signals strong and prevents them from leaking out. And in MS, it's this myelin sheath that's under attack.
Okay, that makes sense. Now, I know there are different types of MS. Can you walk us through those?
Absolutely. The most common type is relapsing remitting MS, or RRMS.
Relapsing remitting. So the symptoms come and go.
Exactly. People with RMS have periods of relapse where new symptoms appear or old ones worsen, followed by periods of remission where they partially or completely recover. It's like the disease is playing hide and seek with the nervous system.
That's a good way to put it. And how long do those relapses and remissions typically last?
It varies from person to person. Relapses can last anywhere from a few days to a few months, and remissions can last for months or even years.
And then you said there's secondary progressive MS, right?
Right. Secondary progressive MS, or SPMS, usually starts out as RRMS, but over time, those relapses become less frequent and the disability gradually progresses, even during those periods of remission.
So it's like the disease gets tired of hiding and decides to settle in permanently.
That's a good way to think about it. And then there's primary progressive MS, or PPMS.
How is that one different?
With PPMS, there are no distinct relapses and remissions. Instead, there's a slow, steady progression of disability from the very beginning. It's like the disease is slowly but relentlessly chipping away at the nervous system.
Wow, that sounds incredibly challenging.
It is. And unfortunately, PPMS is less common than RRMS, but it tends to be more aggressive.
And finally, there's clinically isolated syndrome, or CIS. What's that one all about?
CIS is a bit of a wild card. It's like a single episode of neurological symptoms that lasts for at least 24 hours and is caused by inflammation and demyelination in the central nervous system.
So it's like a preview of what might come later.
Exactly. Some people who experience CIS go on to develop full-blown MS, while others never have another episode. We don't yet have a way to predict who will and who won't.
Okay, so there are 4 main types of MS, each with its own unique course and prognosis. But how do we actually go about diagnosing it? What are some of the key things we look for?
Well, there's no single test that can definitively diagnose MS. It's more about piecing together the clinical picture.
Back to detective work again.
You got it. We start with a thorough medical history and neurological exam, looking for any signs of neurological dysfunction.
So we're checking reflexes, muscle strength, coordination, sensation.
Exactly. And then we usually order an MRI.
MRI, magnetic resonance imaging. That's the big donut-shaped machine that takes detailed pictures of the brain and spinal cord, right?
That's the one. And an MRI can show us those telltale lesions or areas of damage in the brain and spinal cord where the myelin has been attacked.
So it's like a roadmap of the disease process.
Exactly. And sometimes we might also do a lumbar puncture or spinal tap to analyze the cerebrospinal fluid for specific markers of inflammation and immune activity.
Okay, so it's a multi-pronged approach, using different tools to gather evidence and arrive at an accurate diagnosis.
Precisely. And sometimes it can take time to get a definitive diagnosis, especially in the early stages of the disease.
That makes sense. And this is a good time to remind our listeners that early detection and treatment are crucial with MS, right?
Absolutely. The earlier we intervene, the better the chances of slowing disease progression and minimizing disability.
Okay, so we've talked about the different types of MS and how it's diagnosed. Now, the big question is, how do we manage this complex condition?
Well, there's no cure for MS, but we've come a long way in developing treatments that can modify the disease course, manage symptoms, and improve quality of life.
So what are some of the key treatment strategies?
Well, medications are a big part of it.
Right.
We have disease-modifying therapies, or DMTs, that can help slow the progression of MS and reduce the frequency and severity of relapses.
So these medications are essentially trying to put the brakes on the immune system's attack on the myelin sheath.
Exactly. And there are several different types of DMTs, each with its own unique mechanism of action and potential side effects.
So it's about finding the right medication or combination of medications for each individual patient.
Absolutely. It's a lot like personalized medicine. And we also have medications to manage specific MS symptoms like fatigue, spasticity, pain, bladder problems. There's a whole arsenal of tools we can use.
And what about lifestyle modifications? Can those play a role in managing MS?
Definitely. Exercise is crucial for maintaining muscle strength, flexibility, and balance.
I can see how that would be important.
And we encourage patients to eat a healthy diet, manage stress, and avoid triggers that can worsen their symptoms.
Okay, so we've got medications, lifestyle changes. What about those alternative therapies I keep hearing about? Things like acupuncture, massage therapy, meditation. Do they have a place in MS treatment?
You know, there's growing evidence that some of these complementary therapies can be helpful for managing MS symptoms and improving quality of life. But it's important to remember that they shouldn't replace conventional medical treatment. It's always best to talk to your doctor before starting any new therapy, conventional or alternative.
That's a good point. It's about integrating those therapies safely and effectively into the overall treatment plan.
Exactly. And it's also important to recognize that there's a huge emotional component to living with MS. It's a chronic, unpredictable disease that can affect every aspect of a person's life.
So it's not just about managing the physical symptoms. It's also about supporting the person emotionally and psychologically.
Absolutely. And that might involve connecting them with support groups, counseling services, or other resources that can help them cope with the challenges of living with MS.
Now let's shift our focus to the role nurses play in caring for patients with MS. It's more than just administering medications, right?
Oh, way more. Nurses are educators, advocates, and compassionate caregivers. We're often the ones who spend the most time with patients, so we have a unique opportunity to make a real difference in their lives.
Okay, so let's break it down. What are some of the key things nurses need to keep in mind when caring for a patient with MS?
Well, patient education is key. We need to teach them about their condition, their medications, potential side effects, and strategies for managing symptoms.
And what about those practical aspects of care? Things like bladder and bowel management, preventing skin breakdown, promoting mobility. These are all things that can significantly impact a patient's quality of life.
Absolutely. And it sounds like we need to be really attuned to the emotional impact of MS, too. It's not just a physical disease, it affects the whole person.
You're so right. Anxiety, depression, even grief, these are all common emotions that people with MS experience.
So it's about recognizing those emotional needs, offering support, and connecting patients with resources like support groups or counseling services.
Exactly. It's about treating the whole person, not just the disease.
Okay, I think we've covered MS pretty comprehensively. Let's move on to another fascinating neurological condition, Parkinson's disease. This one is all about movement, or rather, the lack of it. It is. Parkinson's is a neurodegenerative disorder that affects the brain's ability to control movement. It's like the brain's signals to the muscles are getting lost in translation.
And it's a fairly common condition, right?
It is. It's actually the second most common neurodegenerative disorder after Alzheimer's disease. So the chances are high that you'll encounter patients with Parkinson's during your nursing career.
So what's going on in the brain that causes these movement problems?
Well, deep inside the brain, there's a small area called the substantia nigra.
Substantia nigra. I'm trying to picture it.
It's a tiny but mighty part of the brain that's responsible for producing dopamine.
Dopamine, that's a neurotransmitter, right?
Exactly. And dopamine is crucial for smooth, coordinated movement. It's like the brain's own lubricant. But in Parkinson's disease, the cells in the substantia nigra start to die off.
So less dopamine.
Less dopamine. And as dopamine levels decline, those smooth, effortless movements become increasingly difficult.
Okay, so it's like the brain's lubricant is slowly draining away.
That's a great analogy. And to make matters worse, there's another culprit at play, Lewy bodies.
Lewy bodies, those sound familiar.
They're abnormal clumps of protein that build up inside brain cells.
So, like little protein gangs causing trouble in the brain.
Haha, sort of. And in Parkinson's, these Lewy bodies are often found in the substantia nigra, further contributing to the loss of those dopamine-producing cells.
It's like a double whammy. Less dopamine and those pesky Lewy bodies messing things up. So, what are the telltale signs that someone might have Parkinson's disease? Are there any early warning signs nurses should be on the lookout for?
There are. And you've probably heard of the classic symptoms: tremor, rigidity, akinesia, and postural instability. Think of it as the acronym TRAP to help you remember.
TRAP, okay? I like it. Let's break those down. First up, we have tremor.
Right. That's the one everyone pictures, the pill-rolling tremor.
I've definitely seen that in movies. The person's hand is shaking rhythmically, as if they're rolling a tiny pill between their thumb and fingers.
Exactly. And it's often the first symptom to appear. It's typically more prominent at rest, easing up when the person is actively using their hands.
Interesting. So if they reach for something or start moving around, the tremor might lessen.
Exactly. And then we have rigidity.
Rigidity, so that's stiffness and resistance to movement.
Exactly. Imagine trying to bend your arm, but it feels like a rusty hinge. And it's not just the limbs. Rigidity can affect any muscle group, making even simple movements feel effortful and jerky.
Okay, so we've got tremor and rigidity. What's next on our TRAP list?
Akinesia. That's a fancy word for slowness and difficulty initiating movement.
So it's not just that their movements are stiff and shaky. It's that they have trouble getting started in the first place.
Right. It's like their brain is struggling to send those movement commands.
You might see things like delayed reactions, trouble getting up from a chair, a shuffling gait.
Exactly. All those classic signs of slowed movement. And last but not least, we have postural instability.
Postural instability. That sounds like a balance issue.
It is. It basically means a loss of balance and coordination, which makes people with Parkinson's much more prone to falls.
So as nurses, we need to be extra vigilant about fall precautions for these patients.
Absolutely. Think non-slip socks, clear walkways, grab bars in the bathroom, anything we can do to minimize their risk of falling.
Now, is there anything specific about the way these TRAP symptoms present that might help with diagnosis? Like, do they usually affect one side of the body more than the other?
You're on the right track. These symptoms usually start on one side of the body and gradually progress to affect both sides over time.
So it's like the disease is slowly spreading its influence.
A good way to think about it. Now, it's important to remember that Parkinson's is more than just a movement disorder. There's a whole range of non-motor symptoms that can be just as debilitating.
Non-motor symptoms, so things that aren't directly related to movement.
Exactly. We're talking about things like depression, anxiety, sleep problems, constipation, loss of smell, even cognitive impairment. It's like the disease is attacking the body and mind on multiple fronts.
That's a good reminder that we need to assess the whole person, not just focus on those motor symptoms.
Absolutely. And that's where the expertise and compassion of nurses really shine. We need to be able to recognize and address those non-motor symptoms, offer emotional support, and connect patients with the resources they need.
Okay, so we've talked about the symptoms of Parkinson's, both motor and non-motor. Now, how do we go about diagnosing it? Is there a specific test, or is it more of a clinical diagnosis?
It's more of a clinical diagnosis. There's no single blood test or imaging study that can definitively say, yep, you have Parkinson's.
So it's back to our detective work.
Exactly. A thorough medical history and physical exam are crucial. We're looking for those classic TRAP symptoms: tremor, rigidity, akinesia, and postural instability. And we're paying close attention to the pattern of symptom progression.
And if you suspect Parkinson's, you might order imaging studies like a CT scan or MRI to rule out other conditions that could mimic the disease.
Right. But the ultimate confirmation often comes from the patient's response to medication.
So if their symptoms improve significantly with dopaminergic drugs, That's a strong indication that they have Parkinson's.
Exactly. It's like a trial and error process, in a way. We try the medication and see how they respond.
And it must be such a relief for patients to finally have a name for their symptoms and a path forward for managing their condition.
Absolutely. It can be very empowering for them to understand what's happening and to know that there are treatments available that can help.
Speaking of treatments, let's talk about the management of Parkinson's. Medications are the mainstay of treatment, right?
They are, and the goal of medication therapy is to restore that balance of dopamine in the brain.
Okay, and how do we do that?
Well, we can either replace dopamine directly or mimic its effects. One of the most common and effective medications is levodopa.
Levodopa. Okay, I've heard that name before.
It's actually a precursor to dopamine, meaning the brain can convert it into dopamine once it gets past a sort of barrier in the brain called the blood-brain barrier.
The blood-brain barrier, that's one of those terms that always sounds a bit intimidating.
I know, right? But it's basically just a protective shield around the brain that prevents harmful substances from entering.
Okay, so it keeps the bad stuff out, but it can also block some medications from getting in.
Exactly. But luckily, levodopa is able to cross that barrier and get into the brain where it can be converted into dopamine.
So it's like sneaking dopamine into the brain through the back door.
You could say that. And levodopa has been incredibly effective in reducing tremors, rigidity, and slowness for millions of people with Parkinson's.
That's fantastic.
Yeah.
But like all medications, I'm sure it comes with some potential side effects.
It does. Nausea, dizziness, lightheadedness, those are all pretty common, especially when you first start taking the medication.
So it's important to warn patients about those side effects and reassure them that they usually subside over time.
Exactly. And we can often manage those side effects by adjusting the dosage or timing of the medication. But over time, levodopa can also cause a different type of movement problem.
Really? What kind of problem?
Dyskinesias.
Dyskinesias. That one sounds a bit tricky.
It basically refers to involuntary, jerky movements, sort of like tics or spasms. And ironically, they can be just as troublesome as the original Parkinson's symptoms.
So it's like a trade-off. You're getting relief from the stiffness and slowness, but then you might develop these uncontrollable movements.
Unfortunately, yes, it's a delicate balancing act, trying to find that sweet spot where the benefits of the medication outweigh the risks.
And I'm guessing that's where those combination therapies come in.
Exactly. We often combine levodopa with another drug called carbidopa.
Carbidopa. What does that do?
Carbidopa helps prevent levodopa from being broken down in the bloodstream before it reaches the brain.
So it's like a bodyguard for levodopa, making sure it gets where it needs to go.
Perfect analogy. And this combination therapy, levodopa-carbidopa, is often the first-line treatment for Parkinson's because it provides effective symptom relief with fewer side effects.
Okay, so we've got levodopa-carbidopa as our dynamic duo. What about other medications? Are there any alternatives to levodopa?
There are. We have dopamine agonists, which essentially mimic the effects of dopamine in the brain.
So they're tricking the brain into thinking there's more dopamine than there actually is.
Exactly. They can be effective in the early stages of Parkinson's, sometimes delaying the need for levodopa, or they can be used in combination with levodopa to enhance its effects.
What are some examples of these dopamine agonists?
Pramipexole and opinirole are two of the most common ones. But like all medications, they come with their own set of potential side effects. Nausea, dizziness, sleepiness, even hallucinations in some cases.
So careful monitoring is essential.
Absolutely. And then we have MAOB inhibitors.
MAB inhibitors, what are those all about?
They work by blocking the breakdown of dopamine in the brain, essentially preserving what little dopamine the person has left.
So it's about maximizing the efficiency of the remaining dopamine?
Exactly. They can be used early in the disease to slow progression or later on to boost the effects of other medications.
Okay, and what about COMT inhibitors? I've heard those mentioned in relation to Parkinson's treatment.
COMT inhibitors block an enzyme that breaks down levodopa in the body, which helps prolong its effects.
So they're often used in combination with levodopa-carbidopa to smooth out the medication's effects and prevent those wearing off periods.
You got it. It's all about fine-tuning the medication regimen to get the best possible results for each patient.
This is also fascinating. It's really a testament to the complexity of the brain and the challenges of treating neurological conditions.
Absolutely. But medication isn't the only answer. For some patients with Parkinson's, a surgical procedure called deep brain stimulation, or DBS, can be a real game changer.
DBS? That sounds almost futuristic.
It does, doesn't it? But it's been around for a while, and it's become an increasingly common treatment for Parkinson's.
So how does it work? What exactly is being stimulated deep inside the brain?
Well, essentially, it involves implanting electrodes into specific areas of the brain that control movement. These electrodes are connected to a small device, kind of like a pacemaker, that's implanted under the skin in the chest.
Okay, so these electrodes are placed directly in the brain, and then what?
This device sends continuous electrical pulses to the brain, which helps block those abnormal nerve signals that cause the tremors, rigidity, and slowness.
So it's like overriding those faulty circuits in the brain.
That's a good way to put it. And while DBS isn't a cure for Parkinson's, it can significantly improve symptoms and reduce the need for medication. Many patients are able to regain a lot of their independence and mobility after DBS.
That's incredible. It sounds like something straight out of science fiction.
I know, right? It's amazing how far we've come in treating neurological disorders.
Now, what about nutrition? Does diet play a role in managing Parkinson's?
It definitely does. One of the most important things is to ensure adequate fiber and fluid intake to prevent constipation, which is a common problem in Parkinson's.
Right, I can see how that would be important, especially since some of the medications can also contribute to constipation.
Exactly. And as the disease progresses, swallowing can become more difficult, so it's important to pay attention to food textures and consistency. Encourage patients to take their time eating, cut their food into small pieces, and avoid foods that are hard to chew or swallow.
Those are all really practical tips that can make a big difference in a patient's quality of life.
Absolutely. And here's another interesting point. The absorption of levodopa, that key medication we talked about earlier, can actually be affected by protein intake.
Really? So the timing of meals and medications could be really important.
It is. It's all about understanding these subtle interactions and tailoring treatment to each individual's needs.
This has been incredibly helpful in understanding the complexities of Parkinson's. Now let's move on to a condition that, while rare, can be pretty scary: Guillain-Barré syndrome.
Guillain-Barré syndrome, or GBS for short, is certainly a dramatic condition. It's an autoimmune disorder where the body's immune system mistakenly attacks the peripheral nervous system.
So to clarify for our listeners, the peripheral nervous system is that network of nerves that extends beyond the brain and spinal cord, reaching out to all the muscles and organs.
Exactly. And it's responsible for carrying signals between the central nervous system and the rest of the body, allowing us to move, feel, and sense the world around us.
So in GBS, those communication lines are disrupted.
Precisely. Imagine the immune system, which is supposed to be our protector, turning against its own team.
It's like friendly fire.
That's a great analogy. The immune system mistakenly attacks the myelin sheath, that fatty covering that insulates and protects nerve fibers, leading to inflammation and damage.
And that's what causes the muscle weakness, tingling, numbness, and sometimes even paralysis that we see in GBS.
Exactly. It's like a wave of weakness that often starts in the legs and feet and gradually moves upward, affecting both sides of the body equally.
Wow, that sounds terrifying.
It can be a very frightening experience for patients. And the progression of GBS can be quite rapid, sometimes happening in a matter of hours or days.
So recognizing those early warning signs and seeking medical attention right away is crucial.
Absolutely. Time is of the essence with GBS. The faster we intervene, the better the chances of a good recovery.
Okay, so what are those red flags that should send someone rushing to the ER?
Rapidly progressing weakness in the legs or arms, difficulty walking or climbing stairs, tingling or numbness in the hands and feet, difficulty breathing. Those are all signs that should not be ignored.
And any changes in bladder or bowel control or difficulty swallowing, those would be concerning too, right?
Absolutely. Those are signs that the condition is progressing and affecting those vital functions.
Okay, so let's talk about diagnosis. What are some of the key indicators that point towards GBS?
That pattern of ascending symmetrical weakness is a major clue, especially if it follows a recent infection.
A recent infection like a cold or the flu?
It could be anything, really. A respiratory infection, a gastrointestinal infection, even a minor skin infection. We think that in some cases, the immune system's response to that infection somehow triggers the attack on the peripheral nerves.
So getting a detailed medical history is really important. We need to know what the patient's been experiencing in the weeks or even months leading up to these symptoms.
Exactly. And of course, a thorough neurological exam is a must. We'll check reflexes, muscle strength, and sensation.
And I'm guessing a lumbar puncture or spinal tap would also be helpful in diagnosing GBS.
You're absolutely right. In GBS, we often see elevated protein levels in the cerebrospinal fluid, even though there's no infection present in the fluid itself. It's a distinctive finding that helps support the diagnosis.
What about electromyography or EMG? Can that shed some light on what's happening with the nerves?
EMG can definitely be helpful in assessing nerve function and pinpointing the areas of damage. It's like eavesdropping on the electrical conversations happening between the nerves and muscles.
Okay, so once a diagnosis of GBS is confirmed, what's the treatment plan?
The good news is that we do have effective treatments for GBS. The two mainstays are plasma exchange and intravenous immunoglobulin, or IVIG.
Plasma exchange sounds pretty intense. Can you break it down for our listeners?
It's kind of like a high-tech blood filtering process. We remove the patient's blood, separate the plasma, that liquid part of the blood that contains those harmful antibodies, and then replace it with fresh plasma from a donor.
So we're essentially removing those rogue antibodies and hoping the body will stop producing them.
Exactly. Now, IVIG works a bit differently. Instead of removing plasma, we infuse the patient with high doses of antibodies from healthy donors.
So it's like giving their immune system reinforcements, flooding it with those good antibodies to counteract those bad ones that are causing the trouble.
That's a great way to put it. And both treatments have been shown to be effective in shortening the duration of GBS and improving long-term outcomes.
That's encouraging to hear.
Mm.
But the treatment doesn't stop there, right? Supportive care is also really important while the patient is recovering.
Absolutely. We need to be super vigilant about monitoring their breathing, as respiratory failure is a major concern in severe cases of GBS. If their breathing muscles are affected, we may need to provide respiratory support with a ventilator.
That sounds serious.
It can be. Pain management is also crucial. Many patients experience muscle aches and pains, especially in the early stages of the illness. And we need to be proactive about preventing complications from immobility, like blood clots and pressure sores.
So it sounds like a truly multidisciplinary approach is needed, involving neurologists, respiratory therapists, nurses, physical therapists, maybe even other specialists, depending on the patient's needs.
Exactly. It really does take a village to care for these patients, and we can't forget about the importance of emotional support. Experiencing sudden paralysis can be incredibly frightening and isolating. Reassurance, compassion, and clear communication are vital throughout the recovery process.
Okay, I think we've covered a lot of ground on Guillain-Barré syndrome. Is there anything else you'd like to add before we wrap things up?
Just a reminder that in medicine, in all areas, really research is constantly evolving. New discoveries and treatments are emerging all the time. What we know today might be different tomorrow.
It's an exciting time to be in healthcare. There's always something new to learn.
Absolutely. And for you, our listeners out there prepping for those nursing exams, I want to emphasize the importance of lifelong learning. Never stop questioning, exploring, and seeking out new knowledge.
Couldn't agree more.
Mhm.
The more you know, the better you'll be able to care for your patients.
Exactly.
You know, it's amazing we've covered all of this, and I feel like we've only just scratched the surface.
I know, right? The brain is such a complex organ, and there's so much we're still learning about it.
Speaking of learning, I was reading about some pretty exciting research on new treatments for Parkinson's, especially in the area of gene therapy.
Oh, yeah. Gene therapy is definitely a hot topic in neurology right now. It's basically using viruses, those things that are really good at getting into cells
Right.
to deliver healthy genes into the brain.
Like a little microscopic delivery truck.
Exactly. To either replace or compensate for the genes that are causing the disease.
Wow. So it's like we're reprogramming those brain cells to function properly again.
That's the idea. It's still early days, but the initial results are looking really promising. I think we're going to see some major breakthroughs in this area in the next few years.
That's incredible. It
Yeah.
makes you wonder what the future holds for treating all sorts of neurological conditions.
It really does. It's a very exciting time to be in this field.
It is. Okay, so before we get too carried away thinking about the future, let's make sure we've covered everything you need to know for that nursing school exam. We've talked about seizures, MS Parkinson's, and Guillain-Barré syndrome. Is there anything else you'd like to go over? Any burning questions you have?
I think we've hit all of the major points. You've done a great job summarizing everything.
Well, you've been an amazing teacher.
Oh, thanks.
I do have one final question for you, though. Kind of a big picture question. We've talked about so many different neurological conditions today, each with its own unique challenges. But what would you say is the most important takeaway for our listeners, the aspiring nurses out there as they embark on their careers?
That's a great question. I think the most important thing to remember is that behind every diagnosis, every symptom, every treatment plan, there's a human being.
Right.
with their own story, their own fears, their own hopes and dreams.
So it's about more than just the science. It's about the art of nursing.
Exactly. It's about connecting with your patients on a human level, really
Mhm.
listening to their concerns, understanding their unique needs, and advocating for their well-being.
It's about seeing the person, not just the disease.
Beautifully said. And remember, you're not in this alone. As a nurse, you'll be part of a team working alongside doctors, therapists, social workers, all sorts of healthcare professionals. Don't be afraid to ask questions. Seek support. Collaborate with your colleagues to provide the best possible care for your patients.
It's a team effort for sure.
Absolutely. And you, our listeners, are an essential part of that team.
Ah, that's nice of you to say. Well, on that note, I think it's time for us to wrap things up. Thanks again for joining us on this deep dive into the neurological system. It's been a real pleasure learning from you.
The pleasure was all mine. Good luck with those exams, everyone.
You've got this. We'll be back next week with another fascinating topic. Until then, stay curious and keep those brains buzzing.